Hello, Femi. Good afternoon to you. I trust you are doing fine today. I've now finished work on the influenza data story, the data medical staff planning project, and I'm here to present to you my data story that has already been uploaded to Tableau Public. Um, okay, if you recall, the purpose of this project is to plan for medical staff for the oncoming influenza season in the US. You realize the motivation for this project is the fact that year in year out, influenza season comes in the US and the United States, and then vulnerable population, people who are in the advanced age from 65 and above, and then young people between age 0 to 4 based on history have been affected, and then they develop complications because as a result of influenza and need they often eventually land in hospitals. And then because of the sheer number of patients in the hospital, this often stretch medical staff in the hospitals, and clinics across the USA. So the essence of this project, as instructed by the stakeholder, key of which is the medical staffing agency of the United States, which provides temporary staff. The essence of the project, on the basis of that, is to use the data that we have to plan for the deployment of medical staff precisely in such a way that the plan will be precise for across the locations, all the states in the United States, and then hospitals and clinic within. Now, the objective the of the project, therefore, is to determine when to send staff, how many to send to each state, and then the agency covers all hospitals and clinic within the 50 states in the United States. This visualization is showing us the planning outlook. We are planning for the whole of this 50 states in the United States, and this is just showing us population dynamics in the United States. The visual is showing us here is this a choropleth, a color map that is using a population figure, where I'm showing here average US population estimate by state 2009 to 2017 based on the data that we worked on here. And we are seeing California here having the most population at almost 39 million people. Going over to the next dashboard, here I'm exploring based on the data sets that I work with. I'm asking the question, what is the data saying? Excuse me. Now, essentially, the data that I work with, I will first talk about the research hypothesis that I used. And the research hypothesis goes like this: if the population is vaccinated before influenza onset, the flu vaccine will be effective on children and older adults, but less effective on the elderly. So what we are saying here is then leading me to the statistical testing that was done. So after profiling, cleaning my data, profiling, and then going ahead to analysis, I went ahead to look at the relationship between variables, which correlation, the visuals that we are seeing here, is a strong way of showing relationship between variables. So the statistical testing essentially is to look at the variables that we have, the columns that we have in the data set, and see which one have relationship with each other. In doing this test, I find out that deaths of 65 and over years, I find out that the variable of death, total death, have an impact. I mean, has a relationship with the population, of 65 and over years, and also relationship with total population total population, in each state. So what am I trying to do here? The statistical testing essentially narrowed down to looking at the key vulnerable group that the data is throwing up, the deaths of 65 and over years, compared to the deaths of 55 to 64 years age group. And then this was tested statistically. Here, what the data that I have here is that I uploaded on Tableau Public is essentially a consumption for the general public. But for you, I know you are more interested in terms of what is the details of, as a data analytic professional, you are more interested in what is the details of the testing. Now, the p-value that I use, the significance level that I use is 0.5, which means a confidence level of 95%. And then I compare the mean of the group of deaths of 65 and over years with the mean of deaths of 55 to 65 years age group. And then the p-value that I obtain eventually show that that I obtain eventually to up a figure of 6.85 exponential 10 to minus 47, which showed that is extremely smaller than the significance level of the alpha of 0.5 that I was working with. So this informed me based on principle and statistical fact that the difference between the two means is significant. That is, the means of death for 64 and over years that is greater than that of death of 5 to 64 years is significant. It didn't just occur due to random chance. So in that case, the null hypothesis that was saying that there's no difference between the two means was rejected, and then the test was concluded. I also went ahead to do the same thing to compare the mean of the death data, the count of death for age 55 to 64 with a lower level of age group, which is 45 to 54. So it also showed the same thing, that the mean for 55 to 64 is greater than the mean for 45 to 54. So which means the result is agreeing with what I proposed in the hypothesis, that the population is vaccinated before the onset of influenza. The flu season will be, the flu vaccine will be more effective on children and older adults, but less effective on the elderly. So that's what the data is saying. Here I have visual that is showing. I looked at the relationship between the death of 65 and over years age group and the population of that group, and what I have is a very strong correlation, which has an R value that is close to 1 or 0.9 something. Now, to also compare this with the entire population, I did I compared the mortality rate in the total population with the percentage of population of 65 and over years age group. Yeah, the visual here is showing that relationship is somewhat weak. It's much weaker than what we see in the first visual, but it's probably expected given that the population of 65 and over uh, years age group is much small in terms of fraction compared with the total population that we are relating this mortality rate with. So going to the next slide, I mean dashboard. What I'm showing here is to further explore what is the what the dynamics within the death data that I have. I'm trying to look at to pinpoint that vulnerability actually rests with the age group 65 and above. So here I'm showing two plots, I mean two charts essentially. A box plot of the death count and also a histogram of the data. So and we can see here that charts are showing vulnerability in for influenza is dominant with the 65 and over age group. If we can see the death count for if this were to be a live Tableau document, we'll be able to interact with this chart and see the detail. But essentially, the picture, I mean, the chart is telling us from the box plot to the histogram, we can see the wide, stretch of data between 0 and 350 in terms of count and magnitude of data within 85 and above years age group. The same thing for 75 to 84. You understand? So, and the same thing for 65 to 75 to 74 years age group. So, if these are the three subgroups that belong to 65 and over years age group. If we compare this with the other group from 55 to 64 down, we will see that the 65 and over years age group is dominant in terms of the count of deaths that we have, records of death that we have. So if we come here again on the histogram chart, you will see the color. My color scheme here is showing tilted is darker for where the dominant data is. We can see the data is showing that between the 65 to 85 and above is where we have the most of the data for frequency, for death counts. That's what. So this is trying to narrow down further that the data is telling us that vulnerability resides with 65 and over years age group in terms of influenza death. So I will go ahead to the next slide, with the next dashboard. Here, what I'm doing here is essentially after having established that the dominant factor, for vulnerability resides with 65 and over years age group, and in tandem with what the research hypothesis is trying to do. Having established that that's where the issue are, now I want to look at history here, the history of death via a temporal chart, and then going ahead to use that to forecast what will be the death for the next year based on the plan 2018 according to the project. Now here I have data from 2009 to 2017, and I'm here showing on line graphs for each of the states in the United States, putting out that data in a line chart for each of the states. and we can see here the highest data for a particular year is 6,387, which is a data for this line represents California, which has the highest. And then the lowest line here is representing Alabama, which has 0,000 across the year. So that is the trend. If we are on Tableau, we'll be able to interact with this chart and be able to see this is on Tableau. We can see that we can filter for each year and see the trend. We can filter for states and see what each state is looking like. You see that Alaska here has the faintest green color, like I said, which is the least, is showing 0 deaths for all the years. That's why we have 000 minimum. So if we are to be on Tableau Public Life, we will be able to do work on the filter and be able to see one by one. Now that is what data is telling us based on history. Now the historical data, now in the second chart, I'm now using that to do a projection, which is a forecast for what will happen for 2018. And this has been done with the help of the tools in Tableau, which essentially use exponential smoothing, with the insert of the function of seasonality to ensure that we get the best result for the forecast. Since this the project we're talking about is also impacted by seasonality. Influenza has a season, starts around is between fall and winter. So it starts around October, peaked by that October, around 2 months in October and April. Sorry, in October and February, and it can run till end of March. So that's why seasonality is an important thing to be an important factor to be in my forecast, which is also there. So my chart here is showing the forecast. You see the forecast for 2018 for California, for instance, is lower than what it was in 2017. So I'll talk more about the forecast, later in the last in the next dashboard I'm going to now. But essentially, what this dashboard achieved for me is to be able to do a forecast based on history for each of the states, and then use that forecast to move ahead to plan, what should be the medical staff ratio per state, sharing per state, based on what the forecast is telling us. So which is what I'll be sharing in the next slide. So here, which is the last dashboard, essentially we have compiled a list of all the forecast for all the states, and then added it, and then used a fraction. Use the contribution from each state as a fraction. To determine a fraction of medical staff that should go to that state. We can see clearly here now that California, having the highest figure for forecast, is having the highest share of medical staff, which is 12.44%. So regressively downward like that until we get to Alaska. See, Alaska here has 0% share of 0% share of medical staff, based on what the projection is saying and based on history. So we also, if we are to be on Tableau, just like I've said, for each of these states there are 3 elements that is there if we're on Tableau, as I interact with this chart now, it will be showing us figures of values that are there. We have the share of influenza projection, debt projection for 2018 for each state. We have the share of medical staff percentage for the state, the rank of the state, and then another important expectation that the project objective, expected of me to score each state on three categories of classes, whether it's a low need state, medium need state, or a high need state, based on the projection of debt for 2018. So California, for instance, with the highest figure of debt projection, is on a high, in fact, the highest need state. You understand? And then going down like that to Alaska, which has zero projection, is on the low need scale and the least amongst the list of state based on the projection for debt and the need for medical staff. So this is concluding the planning plan in term. The planning deployment plan, and then medical staff need plan for the project. So then the other section here is talking about conclusions and next step. So the conclusion is saying essentially that we have determined the deployment plan for the upcoming influenza season of 2018 based on the data that we have shared, and then what the variable that the data showed up as the strongest variable in terms of determining how we will share the data, which is the vulnerability of the age group 65 years and over. So, and then we have done that. Then the next thing that I'm sharing is the next step. What will be the next step? The next step essentially is to determine the level of availability, the number of availability, total availability of medical staff from the agency, because part of the project implementation is that we cannot have more than what is available with the agency, and then we want to optimize the sharing fraction based on what the data is saying, to be sure that what we get in terms of share for each state will be optimum, in terms of staff to patient ratio, for each state, and in terms of need. So when we have the total number of medical staff for the agency, we can then use the sharing ratio or the percentage to know what will go to each state. Then another thing is point number 2, about next step is, we know the data from CDC says that influenza, the virus is available across the whole year in the United States, but the cases of hospitalization, infection, and the extreme cases of death happens between within fall and winter. And then the severity of these implications, infections, hospitalization, and death, vary from year to year. So we just know that the best point in time, or the best month in year to deploy the medical staff is October, say the beginning of October, and then be ready, and then get the staff to get to locations to start work. So another item, on the next step that I didn't list here, which I'm going to be sharing in the document that I will send to you after this, is we also need to look at the factor of staff to patient ratio. It's going to be a very key metric that we will use by looking at the number of hospitalization in each hospital that the medical staff are going to be deployed to. So the staff to patient ratio normally nurse to, which is medical staff to patient ratio, which typically I'm talking about nurses now. In the US, is 4 or 5 patients to one nurse. So once we don't have a ratio that exceed this, once we don't have a ratio that exceed this for each of the clinic or hospital, then we are good. You understand? Then we are good in terms of ensuring that each hospital or clinic like that will be good in terms of the number of staff that we shared to continue to work until to keep up to ensure that our projection is rather low and not higher in terms of death. So, but for any particular clinic or hospital where the number of hospitalization is going far higher than when compared with staff to patient ratio, then there's an issue there. We need to now look at other locations within around there or across, first around the location to see if the situation is better in adjoining location. I mean, it's less serious in adjoining location, and then we can move some staff from such adjoining location to the location where we have issue, to ensure that, because we don't have, that is what the medical staff, the number of medical staff that the agency gives us is what we are. The agency has is what we have. We cannot get. There's no resources to get additional medical staff. So that's a project, and that is my presentation of it. Thank you. I'm going to send the complete work in the documents, and then my answers to other questions to you in the PDF that I'll send to your inbox. Thank you very much.